The next section is the framework for occupational therapy interventions geared towards improving motor performance. In regards to functional use of the arm and hand, occupational therapy has intervention strategies to prevent and reduce mechanical constraints to functional use, promote the capacity to generate contractions of specific muscles in a paralyzed arm, prevent learned non-use, provide opportunities for patients to practice using their available function by matching task demands to the person's current capabilities, develop effective motor programs for reach and grasp, and help patients develop task analysis and problem-solving skills so they can continue to use their arm and hand in a variety of new situations after OT rehab. In order to prevent mechanical constraints, we need to examine what they are and how to alleviate them. The first constraint is pelvic and trunk alignment / mobility. Changes in posture of the pelvis and trunk affect the position of the scapulae. Changes in scapular position affect stability and mobility of the scapulohumeral joint and therefore upper extremity function. So good posture is a prerequisite for upper extremity function. Spasticity impedes joint mobility, dissociation between segments, and production of active movement of antagonist muscles. Interventions to reduce spasticity in order to increase function include slow, prolonged stretch and relaxation strategies. For functional motion of the hands and arms to occur, the scapula needs to be in positions of 5 degrees of upward rotation and 30 degrees anterior to the frontal plane. After a stroke or brain injury, several misaligned positions can occur, such as depression and downward rotation, elevation, excessive protraction, and/or excessive retraction. All of these inhibit function. Interventions that can help this mechanical constraint include making sure the pelvis is in optimal alignment and slow passive stretch in protraction and upward rotation of the scapula. In order for functional movement to occur, the scapula must integrate movement with the clavicle and humerus. If movement is not integrated, the therapist must educate the client on how the scapula should move. Because the shoulder has delicate articulations and structures following a stroke, it is important to prevent injuries while mobilizing the scapula. And these are the safety instructions to avoid secondary impairments of the shoulder. After a stroke, the arm is weak or paralyzed, and there are several different techniques to generate muscle contractions. The first is functional electrical stimulation to selected muscles. This allows non-working muscles to contract and have functional movement of the upper extremity. Electromyographic triggered neuromuscular stimulation is the combination of electrical stimulation with biofeedback of autonomic functions. The client is rewarded for producing a threshold stimulus by making a functional movement. This technique is used in conjunction or before occupation-based interventions. Mental practice has been shown to be effective. Clients are provided with guided instructions to be used outside of therapy time. Mirror therapy is an adjunct to other interventions. It has also been called a different form of mental practice. The mechanism for helping the paralyzed muscle is thought to be neuroplasticity. The ideal session lasts 20 to 30 minutes on top of the usual therapy session. Priming is a technique that pre-excites the brain so it will be easier to elicit the desired response later on. With simultaneous bilateral training, the goal is to increase the affected motor area's inhibitory effect on the contralateral motor area of the brain. Lastly, kinesio tape can be used to either relax or facilitate a muscle. To relax a muscle, the tape is applied distal to proximal, and to facilitate a muscle, the tape is applied proximal to distal. Another goal of intervention is to prevent learned non-use of the upper extremity. In order to combat this, clients are instructed to use the paretic limbs as much as possible. They can use the limb for weight bearing, weight shifting, and practice emerging movement capacities as they come back after a stroke. Clients will need to develop effective motor programs for reach and grasp. In order to do this, they need to have foundational elements first. These include reaching movements are coordinated with movements of eye and head, shoulder, elbow, and forearm motions, orient hand and space to match task demand. Scapular movement is necessary for efficient reach. When reaching against gravity, complex interactions between muscles of thorax, scapula, and humerus provide shoulder girdle stability. Active wrist extension is necessary to achieve efficient length tension ratio, a person assumes a grasp pattern in anticipation, and specific power and precision grips develop last. The next section of interventions deals with improving motor planning in patients with limb apraxia, and there's two types of apraxia. Ideational apraxia is the difficulty relating everyday objects and tools to their common usage and or make significant errors in sequencing multi-step tasks that are performed on a daily basis. An example of this is using a spoon to spear food rather than a fork. Ideomotor apraxia is the inability to match the motor action to specific factors within a task. Movements appear awkward and inappropriate despite knowing what objects are used for. In stroke or brain injury patients, you will rarely see limb apraxia by itself. Additional concomitant problems include aphasias, paresis, sensory loss, spasticity, etc. It's important to tailor each intervention to the client's individual problems. Interventions that address limb apraxia include gesture training. This can be either transitive or cue-based training, or intransitive or no cues training. Therapists can also use task-specific training with aerialist support. However, the gold standard in limb apraxia interventions is compensatory strategy training. Using compensatory strategies has been shown to lead to generalization of using strategies to other tasks in the home. As a summary, some general guidelines for limb apraxia interventions is to use block practice, practice the intervention in the actual environment in which the occupation will be performed, and aerialist learning is stressed.